Hello everyone, welcome to my channel Nursing Ed KGS. So in today's video, we'll be talking about hyperkalemia. Hyperkalemia is characterized by elevated levels of potassium in the blood, resulting from the decreased excretion by the kidneys, the breakdown of cellular protein, bleeding, or say metabolic acidosis. We will be focusing particularly on practical nursing interventions and their implications for patient care. Potassium is an essential electrolyte, crucial for maintaining proper cellular function, particularly in cardiac and neuromuscular activity. Throughout this video, we'll explore various nursing strategies for managing hyperkalemia, ranging from pharmacological interventions to dietary modifications. Let's get started. Now, elevated serum potassium may be thus if your potassium is higher than 4.5 milliequivalents per liter. It is important to note that the specific threshold for elevated potassium levels will vary based on institutional laboratory standards. Labs may have different reference ranges for normal and elevated levels, so of course, follow your institutional laboratory reference ranges and standards. Now, hyperkalemia is often not the primary insult or presentation, but it will rather be the consequence of other underlying conditions. Various conditions, including rhabdomyolysis, where there is extensive skeletal muscle destruction, or tumor syndrome, or if the patient is having kidney dysfunction or renal failure, where the body's ability to excrete potassium properly is impaired, resulting in the accumulation of potassium in the bloodstream. There are also different medications that can induce hyperkalemia, including potassium sparing diuretics such as spironolactone, as well as angiotensin converting enzyme inhibitors such as your lisinopril and your angiotensin 2 receptor blockers, such as your losartan or your valsartan. Medical interventions and treatments can also result in hyperkalemia as well as excessive potassium administration. And this is where intravenous administration of potassium containing solutions, such as potassium chloride infusion that we do use in the hospital to treat certain conditions, can cause hyperkalemia. And there are other conditions that can lead to hyperkalemia. For example, blood transfusion. So when there is blood transfusion with stored blood, as the red blood cell breaks down during storage, it can release potassium into the bloodstream, especially in patients with certain conditions like hemolytic disorders. Another condition where you'll also may see hyperkalemia is Addison's disease. And this is a disorder of the adrenal glands characterized by insufficient production of adrenal hormones, including aldosterone, which can lead to potassium retention in the body. So we'll just take a look at some of those initial order that you may see for a patient who has hyperkalemia. And these initial orders are very multi-phased. And of course, you'll be following whatever your physician thinks will be suitable and appropriate in that patient case. Now, the aim of some of these orders is to, stabilize those potassium levels as well as mitigate associated risk. First thing, an ECG. It will be part of our initial assessment because it will allow the physician as well as the nurse to identify cardiac abnormalities that are associated with hyperkalemia, such as your peaked T waves or widened QRX complexes. The next is digoxin level. Now, if the patient is on digoxin therapy, obtaining a serum digoxin level helps us to assess for potential digoxin toxicity because this can exacerbate hyperkalemia. Now, if the patient is having, or you're suspecting that they are metabolic acidotic, you will also perform an ABG, and this will assist you in evaluating their acid base status and guide other appropriate interventions. There will be a lab panel, and this can include your electrolytes, urea, creatine, blood glucose, which will provide a very comprehensive assessment of the patient's metabolic and renal function. It will also be very important to place that patient on a cardiac monitor. So you can either use your 5 lead or your 12 lead, because again, this will help you to detect and manage cardiac arrhythmias, which are a critical complication of hyperkalemia. You'll also place the patient on a low potassium diet, and this helps to restrict potassium intake. And so, in the overall picture of the patient is that you want to support efforts to lower those serum potassium level. You'll also do well to discontinue potassium supplements or potassium sparing drugs so that you're not further exacerbating those high potassium levels. So if you're working, you'll normally hear someone say, if a patient is having hyperkalemia, we're going to shift the potassium. And it's a very fascinating process. And I'll just, I did this brief graphic as best as I could. And it just gives us an idea where you're having that extracellular fluid, right? Where your interstitial fluid and your plasma, then you have that cell membrane, and then you have the intracellular space. You'll be also having those sodium potassium pump that are in the cell membrane. Now, most of the human body's potassium is contained within cells. The high concentration of intracellular potassium and the low concentration of extracellular potassium is maintained by the sodium potassium pumps. The sodium potassium pumps are also known as sodium potassium ATPase, and they are primarily driven by adenosine triphosphate. And this is a molecule that stores and transfers energy within cells. This pump utilizes the energy derived from ATP hydrolysis to actively transport sodium out of the cell and potassium into the cell against their concentration gradient. However, during certain conditions, such as acidosis, tissue breakdown, or insulin deficiency, potassium may shift out of the cells into that extracellular space. Now, to address potassium shifting, interventions aim to promote that movement of potassium back into the cell, thereby reducing serum potassium levels. And it is important to note that this is a temporary process, but in an emergency, if you're able to shift the patient, so as they would say, that will be very, very good. Now, one of the medications that you will see is calcium gluconate, which is normally recommended, calcium gluconate 10% specifically, if the patient potassium is greater than 6.5 or if their ECG changes. And of course, if the clinician or physician thinks that this will be helpful or it is indicative in this patient's case. Now, calcium gluconate is administered to stabilize the myocardium. Calcium raises the threshold potential, thus counteracting the toxic effect of potassium on the myocardium, which can induce life-threatening dysrhythmias. Now, based on your institutional policies, either the physician is able to administer that calcium gluconate direct, so IV push, undiluted over 5 minutes, and there are institutions that do allow critical trained RNs to do that. Otherwise, they'll be adding that 1 gram of calcium gluconate in 100 ml of normal saline. So your 0.9% normal saline. And you'll either administer it over 20 minutes or 30 minutes. Now, the next two medications that are involved in shifting potassium will be your dextrose and your insulin. Now, extreme hyperkalemia can be acutely managed with IV insulin to drive the potassium inside the cell and temporarily out of the plasma. Glucose must be administered at the same time in order to avoid hypoglycemia as a secondary complication. When insulin stimulates the sodium potassium pump, it promotes the movement of potassium ions from the extracellular fluid into the intracellular space. The shift of potassium ions in the cell helps to lower the concentration of potassium in the bloodstream, temporarily reducing hyperkalemia. And you'll either have your pre-filled 50 ml dextrose syringe or you'll have the vial. And most nurses are able to administer this IV push followed by insulin, of course. And just to reiterate, insulin is used in the management of hyperkalemia by helping to promote the uptake of potassium into the cells. It's important to note that the administration of insulin for hyperkalemia should be done under medical supervision due to the potential risk associated with hypoglycemia. It's very important that before, and this is my suggestion, that before you administer the insulin or initiate that protocol, that you do have a baseline blood glucose level through maybe a finger stick poke. So 3 of the insulin that you may see ordered include the physician may either order your regular insulin. Now, this is a short acting insulin and it's typically administered intravenously, as well as your insulin aspart. It's a rapid active insulin and it can also be used intravenously for the rapid reduction of potassium levels. You may also see insulin lispro being ordered instead. This is a rapid acting insulin, and it's similar to insulin aspart and can be administered intravenously for the acute management of hyperkalemia. Okay, so just to give you an example, the physician at first, just to go over everything, they'll order that calcium gluconate 1 gram, then your 50 ml 50% dextrose IV, and then let's say they ordered Humulin R. So 10 units Humulin R IV push, or, and this is if the patient is hyperglycemic, they'll maybe adjust that insulin and they'll let you know. And you'll administer it in 50 ml of normal saline, so 0.9% over, say, 30 minutes. Of course, follow your institution policy when it comes to IV administration of insulin. And this helps to shift potassium into the cells. So you're moving potassiums into the cells and you're giving glucose concurrently in order to prevent hypoglycemia. Now, when the effects of insulin diminish, the potassiums will shift back out of the cells. Just to note. In terms of nursing interventions, you'll be testing glucose at least every 15 minutes for the first hour. And you'll also want to get potassium levels after. Another medication that you may see ordered is your sodium bicarbonate 8.4%. And it's normally ordered if acidosis is present. Sodium bicarbonate can correct acidosis and cause shift of potassium into cells. Now, the correction of metabolic acidosis with sodium bicarbonate administration triggers a potassium shift into cells. In acidosis, extracellular accumulation of hydrogen ions, in particular, prompts an exchange of hydrogen ions for potassium ions to maintain cell membrane neutrality. As acidosis is corrected and hydrogen ions decrease in the extracellular fluid, potassium ions are driven back into the cells via the sodium potassium pump. The cellular uptake of potassium lowers extracellular potassium levels and thus aiding in the correction of hyperkalemia, commonly linked with the metabolic acidosis. And we'll also want to look at some of those ECG changes in hyperkalemia from normal potassium levels to potassium levels of, say, 8 milliequivalents per liter. At approximately 6 milliequivalents per liter, the P wave flattens, the QRS complex broadens, and the ST segment disappears, with the S wave following the tall, tented T wave. And the ECG, the 12 lead that's shown just below, that shows the ECG of a patient whose potassium was 9.1 milliequivalents per liter. So it's very important for patients who are having hyperkalemia that you are doing a very good monitoring of their ECG. Also bearing in mind that evidence of hyperkalemia is not always visible on the ECG, and research has also shown that ECG waveform changes are not always a sensitive indicator of elevated potassium levels. Nevertheless, there are patients who you will have who, if they're having hyperkalemia, they may have ECG changes. And fatal dysrhythmias can occur when elevated serum potassium levels reach 7 to 8. Hyperkalemia occurs with acidosis or with over aggressive administration of potassium replacement in patients with kidney disease. And hyperkalemia is sometimes demonstrated on the cardiac monitor by large peaked T waves, flattened P waves, widened QRX, ventricular fibrillation, or ventricular tachycardia can also follow. Another medication that you may see order is salbutamol. And salbutamol will also temporarily shift potassium back into cells. Now, when salbutamol stimulates the sodium potassium pump, it enhances the movement of potassium ions from the extracellular fluid into the intracellular space. It is also again important to point out that the potassium shifting effect of salbutamol is temporary and reversible. Once the medication is metabolized and its effects diminish, potassium ions may redistribute back into the extracellular fluid over time. If the patient is producing urine, loop diuretics such as Lasix can increase potassium excretion in the urine. Now, to also reduce potassium in the blood, or to treat hyperkalemia in non-emergent situations, as well as to treat smaller increases in serum potassium, the physician may order non-absorbable potassium binding resins, and these can be administered orally or through nasogastric tubes or rectally. Now, these really do a very good job, I'd say, in enhancing potassium removal. These cation exchange resins, such as kalexolate, help in removing potassium. And normally, the therapy will remove 1 ml of potassium per gram of the drug. And potassium is permanently removed from the bloodstream by these cation exchange resin products. They're placed into the GI tract and they're removed by a stool. And another thing that we could do is to restrict the dietary intake of potassium to, say, 40 mLs per day and avoid potassium containing salt substitutes. You'll also want to limit or discontinue medications that can precipitate or exacerbate hyperkalemia, such as your ACE inhibitors, your ARBs, and potassium sparing diuretics. Now, if the patient is oliguric or non-responsive to diuretics or some of those previously mentioned medications that reduce serum potassium, emergency dialysis may be indicated. Hemodialysis can bring potassium levels to normal within 30 minutes to 2 hours. It is very effective in reducing serum potassium, and the potassium that is removed during dialysis is not replenished. However, it's not permanent, and potassium levels can rise again if the underlying factors that initially contributed to hyperkalemia is not addressed. And just to close off, I will say that long-term management of hyperkalemia will involve addressing the underlying issue, dietary modifications, and sometimes some of those medication adjustments that were mentioned previously. Now, thank you very much for sticking around to the end of the video, and I hope you're encouraged and empowered with more skills and knowledge in order to provide exceptional nursing care. Keep tuning out for Nursing Ed KGS. Stay tuned for more videos.